this discussion about when to order mutational analysis and how we respond to those results makes me want to take a step back and discuss how it's best to monitor patients. What criteria do you use? What have you established in your practice, Doug?
We have tended to continually follow patients, and once they've been stabilized on the drug and they're tolerating it from a hematopoietic standpoint, their blood counts are fine, we test them every 3 months pretty religiously. Now, there are patients that travel a greater distance, and when they meet a very nice response threshold, we may check them every 4 or 6 months, but traditionally I'm getting peripheral blood PCR testing about every 3 months or so.
And are there barriers to testing? So you mentioned traveling from a distance, but are there barriers for the physician or a large practice to be able to follow this?
I think academic centers are sort of set up to do this, to have patients come in regular intervals. We're able to track them pretty well. And I'm worried that there are some practices or some treating physicians in the community that don't understand the importance of the testing. And they may feel comfortable once the patient has normal blood counts and is physically doing well on a drug, and not be following the level of response, the molecular level of response. We do gain a lot of information over time of how patients are doing. We get an early signal for potential resistance or change in response. And I think this information is really vital to try to figuring out what your steps further on down the line are for your patients.
To validate Doc's point, we led a survey in the nation about community physicians prescribing and monitoring patients on CML with TKIs. And we were surprised to see around 2,000 samples from patients. So 15% had never had any karyotype done, nor PCR, and there's no monitoring. So that is scary, where you know that you can have really a good outcome with TKIs, where you can have a survival close to normal lifespan. And yet, I think we should not take this risk, and we should really make every effort to have a good monitoring. That being said, one more item I want to discuss is the monitoring of the PCR. In USA, we're behind the European colleagues, where the international scale is lacking behind. A lot of progress have been made compared to the previous years, where more and more labs are using the international scale, but still some of them, they report the PCR like an absolute value or log reductions, and patients and doctors are confused. And actually the NCCN guidelines, they recommend to do PCR at 3 months and international scale, and yet there are several doctors in the US where they don't do that. They don't have access to that, or they don't do it. And therefore, it's hard to compare studies. It's hard to say, well, X published this paper in JCO, and I want to apply it here, where I'm talking about different testing. So this is really important to take into consideration. And therefore, at my institution, for example, I don't have international scale. So we can convert it. We have the conversion factor, but still we report an absolute value specific to MD Anderson. And I have sometimes problem correlating karyotype with a PCR. And therefore, at the early stage, when I start somebody on therapy, the first year, we do more karyotype and PCR together rather than relying on PCR only. And once you have a good response, CCYR, MMR, obviously we have a less frequent monitoring. We go to 3 months at the beginning and then every 6 months thereafter.
So one can see how this becomes confusing. If I understood you correctly, in the survey that MD Anderson conducted, 15% of patients have never had any molecular monitoring, so any genetic monitoring.
Correct.
Karyotype or routine cytogenetics or molecular studies. And it can kind of be confusing. I think if you're in a busy practice and there's a sheet that you have to fill out and there's cytogenetics, FISH, molecular studies, it's hard to know what to choose. So I think in terms of ease, right, the ideal setting is once someone has obtained a hematologic remission, and we can discuss the merits or not of ever doing another bone marrow biopsy once we've established a diagnosis, but requesting that patients have every 3-month molecular studies via PCR, ideally on a scale that is international standardized.
So the Simplicity trial, which is a big observational study in 7 different countries, is looking at the same issue of how many people are being monitored appropriately. and only 40% of patients worldwide are having PCRs done 3 to 4 times during that critical first year. And just like with Elias's study, 15% of the patients had no PCR or cytogenetics during their first year. So at our group, we send out a survey to 100. We got back 100 surveys from physicians in New Jersey and in Indiana to ask them why they weren't following the guidelines, what was the barriers. And 70% of the people who sent them back, obviously these are more motivated physicians, said they follow them, but 20% of the respondents said they knew about the guidelines and they actively decided not to use them because of cost issues, because of not believing in the guidelines, and because of difficulties with following what the recommendations were. So there are still barriers, even though these are pretty easy from our standpoint. The great deal of physicians across the country still don't understand this disease, and it's part because this is not their major disease. If you're seeing breast cancer, colon cancer, lung cancer, and you have one patient with CML, to take the time to go look at the guidelines can become a little bit challenging. And the cost of doing the test also may seem challenging for some of the physicians.
Yeah, but I think, you hinted at what I think all would agree is the cost of not doing the tests. Not only the cost to the patient potentially from loss of response and possibly progression and leading to loss of life, but there's also medical legal risk. And so, I have not yet been, called to testify in any case where there was inadequate monitoring of a CML patient. But if I were asked and there was a patient who had been managed for a few years on one of these drugs and never had any molecular testing, that is not defensible from my perspective.
Yeah, there was a big study of about 1,200 patients from an insurance company to look at what happened during their first year, and once again, somewhere in that 30-40% were monitored properly. The ones who weren't monitored cost $6,000 more because of the lack of monitoring. They ended up in the hospital at a 40% higher rate. They ended up having more progressions, and actually it affected survival. So there was a decrease in survival by not monitoring patients. It's not going to happen many times because, as we all know, CML is an easy disease to treat. Most patients will do well. I've talked to doctors who said, I have 3 in my practice and they've all done great. But if you start getting enough patients, you're going to lose one here or there that could have been prevented.
Pardon me. What I like to point out sometimes is that it's true that we've made CML an easy disease to manage, but in some ways it's also a very easy disease to mismanage. And I think all of us have been referred cases where that has occurred. And I strongly encourage people in the community to pay special attention because these are transformational drugs, and the potential cost of doing something inappropriate is substantial.
We had a presentation at the ASH meeting again to reflect the cost effectiveness of a certain test and many of the mutations. Apparently in the US, there are certain insurance or some payers will restrict the use of second-gen TKI to nilotinib or dasatinib. They don't give you open access, and sometimes you skip the mutation testing because you want to save some money. So we create a model where we assess whether you do the testing or not, and you create an open access versus restricted to one drug or the other. In fact, if you do mutation testing and you have an open access, you save a lot of money, essentially because you have the appropriate medicine given and you have less progression in the future. So just to highlight that even if these tests are like $500 or $1,000, it's important to do them. We save a lot in the future.
I want to spin it to I want to fast forward, right? There's also another reason to do frequent testing, consistent testing with the international scale, is because we're now learning that there are some patients that with the proper testing, the proper achieving of undetectable states, we may be able to discontinue drugs for some patients. This is not something out and readily we talk about outside of the setting of a study, but now we've got data to suggest there are some people, when they have really good testing, undetectable for a couple of years in a row, might be someone that would be considered eligible to stop taking the drug. And you say to yourself, geez, that to me is a little bit of motivation for the patients to want to be tested, to be able to see if they're achieving that low level. and if they're able to maintain it to a point where you could begin a dialogue, is there a study for me to try to be able to come off the drug, and what are my long-term implications if my testing's really, really good? So I think we have to keep that in mind as well.
Oh, and that should also be motivation for physicians who are concerned about costs, because these drugs cost, in some cases, about $100,000 a year. And if you're concerned about a few $100s on a PCR test every 3 months, I mean, being able to take one patient off therapy is potentially hundreds of thousands of dollars over the course of a few years.